Good afternoon, everyone. Thank you so much for joining us. This is the Tour for Diversity in Medicine. My name is Kameron Matthews. I'm one of the co-founders and directors of the Tour for Diversity in Medicine, and we are ecstatic to be involved with Health Professions Week yet again this year. And I say yet again because what else would we be doing, to be honest? This is such an amazing opportunity for you as students every year, twice a year now, to learn more about us, about health professions, and to hopefully guide you on the path into your future careers. We absolutely love it. But you know what? We have to take opportunities like this to speak with you, not just about your future careers, but about your own health. I think what we really need to be aware of, and I know all three of us on the screen, I'll introduce us very shortly, all three of us really believe in the importance of our own healthcare, and so much of what we've experienced over the past couple of years, what we continue to experience in all of our lives, yours and ours, really does deal with this subject matter of mental health, behavioral health, and hopefully we are going to be able to give you a little bit of information if indeed it gets to the point where you need help, because we all do. We all do, and we want to normalize that in every sort of way. So again, my name is Kameron Matthews. I'm a family physician by training, and I live in Washington, D.C. I'm going to pass it over to my friend and colleague, Brittany Duke.
Hello, everyone. I'm Brittany Duke. As my training, I am a pharmacist, but my job title is Associate Director of Regulatory Affairs. So I'm more on the industry side in terms of pharmaceuticals and things of that nature. And I also live in the DC area.
Hello, everyone. My name is Frank Clark. I'm in the South Carolina area in Greenville, South Carolina, and I am an adult outpatient psychiatrist. Used to do inpatient as well, so I've been in multiple clinical environments, but serve a diverse patient population in South Carolina. So, you know, we're talking about an important topic, which is important to all of us, the topic of mental health. And I want to touch on a topic related to mental health that we often are somewhat afraid to talk about, somewhat hesitant to talk about, and that is the topic of suicide. Suicide impacts not only obviously the person who has completed suicide or attempted suicide, but it also impacts the family. It impacts the community at large. This is some background of what we know. We tend to think about suicide as a cumulative risk factors that occur over time. And so when we're thinking about suicide, we have to look at who that person is as a human being. Who, you know, how did they get to the point where they were under such psychological distress that they felt that they had no other means to go on in their life? And what we find is that there can be some risk factors for suicide. Obviously, if you have a family history of suicide attempts or completed suicides, that can increase your suicide risk. Historical trauma, we see that a lot in our communities of color or historically marginalized communities. Lack of access to care. I'll bring it even present day, where we have seen so much unrest, political unrest, the lack of social justice that is going on, and the killings of Black men and women and other marginalized communities, whereas we look at veterans, we look at individuals in rural communities, we look at individuals in the LGBTQ community. A lot of these communities have been historically marginalized, and this being a historically marginalized community in itself can contribute to a person feeling hopeless and worthless at times. When we look at some of the data, we find that in 2020, I believe 46,000 people died by suicide. So that's one death for every 11 minutes, one death in 11 minutes is my understanding. One death in every 11 minutes, someone has died. That's horrible. We are losing so many people. And then when we think about our youth, right, we think about, and I'm going to pivot to a second. There was a study that came out in 2018 in JAMA Pediatrics where they talked about the racial disparities that we're seeing among suicide. So here's some information that may be new to you and maybe not, but Black children ages 5 to 12, I believe, are twice as likely to die by suicide than their white counterparts of similar age group, in a similar age group. I'm going to repeat that, twice as likely, okay? So we have to think about, why are children 5 to 12 years old of any demographic, right, completing suicide? But when we think about communities of color, why are Black children, for example, in that demographic? I would say the effects of systemic racism can be looked at. We can look at bullying, adverse childhood experiences, those experiences that happen prior to 18, where a child may have been raised in a home where mom or dad or auntie or uncle also had a mental health condition, or one of the family members was incarcerated, or that child was the recipient of physical neglect or emotional neglect. So these are just some things that, when we think about suicide, it is I would say it's a public health crisis that needs to be addressed. And we need to be mindful that not when the person who is grieving and dies, the one who has completed suicide, we also have to think about the community more and saying grieves as well. And we have to be sure that we don't shame the person who has completed suicide. This is not a moral failure. This is not someone who just didn't have enough faith, or that, is a coward. This is a person that was hurting. And when someone dies, whether it be by homicide or suicide, that person is hurting, but we also hurt.
Yeah, I would say to that last point, that was really great. The shift between the terminology from committed suicide to death by suicide. So that goes to your last point. So yeah, that's very important.
Exactly. Brittany, I'd love to hear any thoughts you have. I think in particular, one thing that I know we highlight often, you may even hear students as you learn more about the health professions, that unfortunately rates of mental health issues, depression, anxiety, and even suicide are increased amongst health professionals, which is alarming to say the least. Brittany, do you have any information you'd love to share about that?
Yeah, I would say the main issue is burnout, and that has been an issue even before the pandemic. I think one stat was like 79, almost 80% of physicians have been impacted by suicide and burnout and things like that, even before the pandemic. So now that it's just like 2-3 years in, it's like that just skyrocketed, and that was at 79%. So, I mean, I know there are some initiatives like the National Institute of Occupational Safety and Health. They launched an initiative last year that kind of kicked off around this time, with actually like November 2021, to kind of focus on this issue of mainly work stress and mental health amongst healthcare workers. Because it's really bad, to be honest. So I would say that in addition to burnout, which includes like long hours and all the different kind of exposures that all types of healthcare workers have, and that's just like everybody, but to focus on health professionals. So you mean like people with doctorates or things like that? Like that's even another issue as well. So like the long hours, I know like I experienced burnout just from transitioning from in office to at home, because you work longer hours because you're more accessible, because your computer is right in your home. So if you get an email, you're just, so there's no more 9 to 5 with me. It's like 24/7 because everybody has access to me. So you end up working longer. And that was, I mean, that's kind of like what some of the companies are doing, of transitioning people back into the office type thing. But that's just people who have that luxury of working remotely. A lot of people are grinding in the hospitals, in retail pharmacy, things like that. So in terms of like all the exposures to all the other related stress and demands and things like that, like even retail pharmacy, I know, like when I started in retail pharmacy, we always had a break for lunch, like 30 minutes, but most people didn't. So now everybody, I think by now, has at least half an hour of lunch guaranteed for retail pharmacists. And that took a lot of initiative from a lot of people and things of that nature, because I saw so many crazy things from some of my people that I shadowed in pharmacy school, with some people having miscarriages for just standing for like 12 plus hours. Wow. And that's just the women. So I'm like, what? That's crazy. So stuff like that. But getting back to kind of like the focus of suicide, it is a major impact, particularly on the Black community, Black and Brown community, because of the racial tensions and things like that. And one thing that many employers are trying to kind of work into as like an employee benefit is having trainings and access to mindfulness and also emotional intelligence. And I'll talk about those things later. But I know, just for example, with me, just being in having a therapist is very, very key. And just focusing on the here and now, just being present and having acceptance for certain things. That's like practicing mindfulness, and that's just how that is worked into. But particularly emotional intelligence. A lot of people do not have empathy. They sympathize in whatever, but to empathize and have the emotional intelligence where you are perceiving and interpreting emotions of others and communicating that effectively. So those two things are very important for employers to implement into employee safety, like mental health and things like that. And then pivoting to just the DSM-5 TR. It was just updated this year, I think in March. And my therapist is like, oh yeah, by the way, I got a new DSM-5 and it's TR, which is just text revision. But it was amazing. Like this version actually added grief, symptom codes for suicidal behavior and non-suicidal self-injury. And then as a bonus, they focus on historical role of racial discrimination and clinical diagnosis in 2022, literally in 2022. So all these things were in there in the beginning. I was appalled. I was like, you're telling me they did a brand new update for this? I was like, oh, wow, wow. And I don't even want to go into social media because that's just another thing. But those are just some key things that everybody's dealing with in general, but mainly the healthcare workers that are doing so much so that people have access to care and so many other things, so we can work on our mind, body, and soul. Because people forget about that, because they're like, if it's not a physical ailment, I don't see it, I don't know, it's whatever. They don't consider mental health as a major issue unless someone gets shot and dies, and that's the end result. That's the problem. So that's just what I've experienced and what I can add to this conversation.
I love it, Brittany. No, thank you for that. I think I can remember vividly the emotions that I had in addition to I'm agreeing to everything, the burnout, the difficulty of my role, the stress, the fatigue and the like. I can remember vividly one of my first years practicing, and I was a doc at Cook County Jail in Chicago. I absolutely loved working in correctional medicine. Significant focus necessarily on their mental health, not necessarily a lot on our own. And I remember going home for the holidays, my first Christmas. And so I had only started working like that summer, so a couple of months. And I remember sitting there and my parents holding me as I cried and just like let out a significant amount of, I would even call it trauma, just emotionally. I still cry out my emotions and my feelings. And it wasn't because I was stressed. It wasn't because I was fatigued. I was crying because my patients weren't with their parents. That's literally what I was thinking, that my patients were behind bars, that my patients were going through a painful experience that was worsening their health and their well-being, and I could do nothing about it. And as a physician, that is my goal, to help them. But I knew that there was a limitation to my help. And I just remember feeling helpless. And I think that form of vicarious trauma, stress, however, that we actually take on from our patients is also something that unfortunately we don't acknowledge. Like it's more like, tough it up, you're supposed to handle this, you're a professional and the like. But to see that time and time again and feel that helplessness, to feel that what you were trained to do isn't enough, is overwhelming at times. And I think that hits a lot of us as well too. And of course we saw that every day during the pandemic, right? So thank you for that, Brittany. I just wanted to add that experience, because I remember the sadness, the emotion of that. But as my therapist says, let's move on. We all have therapists. Hopefully everybody watching us has therapists.
I fully support and endorse everybody doing their own therapy. So
exactly. No, as my therapist says, we're just gonna, keep it moving, right? Keep the party moving. I think if we're having this conversation about suicide, we have to recognize this kind of pivotal moment that we're in right now, where we are not only recognizing, as both Brittany and Frank have raised, the increasing unfortunate statistics that are in front of us, but thankfully as well, the new resources that are available for us, right? And as we unfortunately have seen time and time again, especially in Black and Brown communities, we need another option. We need someone to call other than 911 when we are looking for help, because the police are not always going to be in any way your best bet. And particularly when we're talking about mental health, it's nothing against them. I don't care if you are about blue lives or Black lives or whatever, they are not trained in this work. Shoot, a lot of times health professionals, we're not trained enough in this work. Frank is, but Brittany and I are sitting here like, I could use a little more, right? Like, we need people to help us in that crisis moment, who are actually trained to do that. And there is a new resource for all of us called 988. Hopefully many of you have heard of this. This is an option of just a 3-digit dialing code like 911, but 988, a different phone number that actually routes callers to the National Suicide Prevention Lifeline. It's something we've had, but we never had this very specific, beautiful, short, memorized number that in a time of crisis you can call. You've had 311, you've had 411, you've had 911, but here you go, 988, and it is now active across the United States. When anyone calls, texts, or chats, you can do anything to this number. You actually get connected to trained counselors that are part of this existing lifeline, this existing network, and they're trained to listen. They're trained to understand your problems, provide support, and connect you to resources if indeed you need them. Like I said, the problem is 911 isn't set up to address mental health needs. It's a very blunt mechanism, right? We send cops in a very frenetic sort of way to respond to situations that deserve a lot of nuance, to say it bluntly, right? And you either end up in an emergency room, you end up waiting for something, and oftentimes it leads to tragedy and trauma, sometimes that might have occurred if 911 wasn't called, which is the disappointing part. This 988, this suicide prevention lifeline new access point is pretty critical. According to our government, in 2021, the lifeline to which you'd be directed actually received 3.6 million calls, chats, and texts. That's phenomenal. However, I hate to say this, only about 85% of the calls, 56% of the texts, and 30% of the chats were actually responded to. This is the difficult part. So we've stood up this new function. We have this new capability, but unfortunately not every state, not every local county is well staffed enough to actually be able to be there on the other end. So I don't in any way want to make you feel nervous about using this line. I want you to call this line, but I also want you hopefully to advocate for your brother or sister in your community and talk with your elected officials, talk with your state governments to put resources behind these lines, because if you yourself don't need help, someone you know will, and we need to appropriately staff the 988 line. The Biden administration, where we currently are, has dedicated $432 million. I mean, that's an increase to really increase the capacity of local and backup call centers and provide even sub-networks for Spanish speakers. I mean, if we're even talking about how we're actually going to help our communities, we need to make sure every language is spoken on these lines and that we are there from the very beginning, and we're going to be there until that crisis moment passes. And particularly for me, having worked not only in the correctional setting, but also with veterans for the past several years, this capability, this availability is so critical at every moment, exactly at that moment when it's needed. So again, your advocacy as students, as professionals is so needed so that we can make sure that we are fully implementing 988. The last stat I'll throw out there, and I hate to say this, unfortunately, we're close to about half of public health organizations around the country, counties, states, or whatever your entity is locally. Only about half have really put in the effort to develop plans about how they're going to staff 988, how they're actually going to develop it, support it with a budget and the like. So again, please use the number. It's connected to a national network. Don't get me wrong and everything, but for us to actually be able to answer the calls and everything, every local entity, every state government, not just the federal government, needs to tie some resources to it. So help your fellow man and please advocate for this. And by all means, remember 988 when you need a moment, even if it's not about taking your life, even if it's not about harming yourself or whatever. These people are here to help you, and we hope you turn towards them and seek the help you need when you need it. So thank you.
Yeah, I second the 988. It's I know in South Carolina, where I'm at and based and practicing, we are advocating heavily for more funding because you can't have a sustainable lifeline, crisis line, if you don't have the people to help operate the lifeline. And so I couldn't be, I just wholeheartedly agree everything what you said, Kameron, about advocating and reaching out to your state legislators and advocating, because if this is going to be a lifeline that can potentially save lives. And that's what we're looking at, right? We're looking at longevity, preserving the life, liberty, and the pursuit of happiness for all communities. And so I think 988 is a piece of that puzzle as we look from a strategic focus standpoint of how we are going to decrease the number of suicides. You know, the goal has always been, I guess, you know, these zero suicide initiatives. 46,000 is too much. Even one, I would say, is we don't want anybody ending their life. One of the things I've always said about the hardest thing I think about being a psychiatrist is that, you know, I know inevitably that I'm going to lose someone to suicide, and I've lost several patients throughout my career to suicide, and each time it hurts. It's difficult. So I think we can do more. We can do more to help our fellow man, fellow woman, fellow child. You know, I think a lot of times when we have these conversations, people always ask, well, where is the help? What are the resources, right? How can I help a loved one who is struggling? And I would say 988 is one of those resources, but it's not the only show in town, right? You know, we have national organizations, but also at the state level, that are committed to helping raise awareness and dissolving the stigma that unfortunately continues to be perpetuated throughout our society, and that can come in the form of public stigma, that can come in the form of our self-stigma. As communities of color, we still have relatives and friends that say, why do you see a therapist? Is something wrong with you? We have to change that narrative. We don't say that when someone has developed cancer or diabetes. We don't say, what's wrong with you? We say, we're praying for you. We let you know, how can we help you? We reach out and extend our hands, and we're not doing that when it comes to mental health. I want to put in a plug for NAMI. The National Alliance of Mental Illness, a great organization that has been committed to raising mental health awareness. They have educational groups for families, because I think when we talk about, again, that person who is experiencing a mental health condition and or a substance use disorder, I'll throw that in there as well, because we often don't talk about addiction. We kind of think of them as separate, but the majority of people with a mental health condition also have a co-occurring substance use disorder. And so NAMI is an organization that focuses on peer support. It really helps, I think, someone who has lived, who is battling a mental health condition, to see someone who has that lived experience, who can talk with them and say, I'm in your shoes. Doesn't mean they exactly know everything that person is going through, but we see that as healthcare providers, right? We speak that language. We understand, the lingo and things when we're talking about burnout and things like that. And I think that can also, you can equate that with peer support and mental health. Mental Health of America is another organization that also raises awareness for
Oops. He might have frozen. Oh, Frank. Oh, he said Mental Health of America. I was looking forward to hearing it. I don't know too much about them.
Yeah.
Oh, no.
I hope he comes back. And you made a good point about NAMI, and then also his point about where people combine substance abuse and mental health, because they kind of leave it out. So
Yep.
SAMHSA is another good resource.
Exactly.
Yeah.
Oh, and he dropped.
Oh, no.
Yeah.
I hope he comes back.
All right. Well, Brittany, I thank you so much for this conversation. I thank you for sharing your insights, your experiences. This is so critical, and I hope we've just shed a light on a subject, even if it's not for someone themselves, maybe for a friend, because we have to take care of each other. And so much of this is just making sure we know about resources, right? And how to help each other. So thank you for your time, Brittany. Thank you, Frank. I'm sorry you had to drop off.
Thank you, Frank.
I know.
It was wonderful information. I was enjoying it. I was like, what?
I know. I gotta look up that second organization, Mental Health of America. But hey, it's the Zoom world. It happens, and we just keep
right.
So thank you, audience members. Thank you so much for just taking a little bit of time with us today to learn a little bit more about the importance of helping someone, about asking questions, and recognizing that suicide is something that hurts all communities and that we can do something about it. This is Tour for Diversity in Medicine. Again, we thank you so much for joining us, and please enjoy the rest of Health Professions Week. Thank you again. Bye-bye.